A great day to everybody. Hello, my students. We'll now be discussing the world of pathogenic bacteria, and we start with two most common bugs that usually are causes life-threatening infections and still brings headache to us physicians. So these are all taken from the rapid review of microbiology and immunology. And this is your professor, Dr. Cabrera, hoping that will teach you something and you'll be learning something for today's lesson. In discussing Corynebacterium, so this is a microscopic representation of your Corynebacterium. This is a uh, bacilli that has a swollen end, looks like a tub shape almost. It's like a matchstick that is colored blue. So this gram positive, that's why it is colored blue. So the significant human pathogen is here, Corynebacterium diphtheriae. It usually will form black colonies in tolerate agar, and it has an irregular swelling at one end and then the club-shaped appearance, as you can see in the representation in the microscope. And it contains toxins, your exotoxin, like your A and B exotoxin, which inhibit protein synthesis in mammalian cells. And because it inhibits protein synthesis, it will lead now to the death and disease manifestations. Okay, for Corynebacterium, it contains a bacteriophage called your lysogenic bacteriophage, or your otherwise called your beta-prophage, which carries your toxin gene. And there's a rule: no phage, there will be no toxin produced, and if there's no toxin, there will be no disease. So how do you acquire it? By inhalation of respiratory droplets, through bracing the skin with cutaneous route, and the manifestation of your systemic toxemia. Okay, so the inhalation of respiratory droplets from infected individuals, including your asymptomatic immunocarriers, will later on manifest as swollen neck or bull neck. However, for the cutaneous route, the diphtheria is acquired by skin contact and entrance of the organism, which is through breaks in the skin, later on developing to easily into papule, leading to the formation of your chronic non-healing ulcer. And in this route, there can be mild systemic manifestation. But the more severe is when they have bacteremia, and later on the spread of your toxin, your Corynebacterium diphtheria toxin, that will now cause damage to distant organs, causing myocarditis, neuropathy, and renal tubular necrosis. So how can you remember your Corynebacterium diphtheria in summary, so we can make a bit of a test story? Now you're walking and you'll see a blue matchstick that is so big, so that you can remember it, it hits your head. And later on, it is shoved into your throat. And the contact in your throat will now produce abrasions, and later on you develop now the grayish uh, pseudomembrane. And because the end of the stick, the swollen part of the stick, is so huge that it causes swelling in your neck, causing you to have bull neck. And later on, what happened to you happened to your classmate also, and your classmate now tried to bite you, so there is no contact, okay, in your skin, and there's now a break in the skin, and later on you develop papules, and in a period of time it causes to produce chronic non-healing ulcer. Then we have mild systemic manifestation. But the problem is because of the large amount of your Corynebacterium diphtheria that produces a lot of toxin because it has a fudge in it. Now, later on, with a bull neck with a blue club shoved into your throat, and you develop a pseudomembrane that is colored gray. Later on, you felt chest pain. That is your systemic manifestation of your toxemia. You can develop chest pain. That is your myocarditis. And later on, you cannot feel anything. That's neuropathy, and in your shock of your life, when you pee in the white toilet bowl, you will see a very red urine. That is your renal tubular necrosis. Now, so these are your graphic representations of your chronic non-healing ulcer in the leg and your pseudomembranous grayish pseudomembrane in the area of the tonsil. So how do we prevent and treat this infection? Fortunately, there are many smart people, smart scientists and doctors who went ahead of us, and because diphtheria is giving us problems, it kills many children. They develop a vaccine, and the vaccine is geared towards the toxoid, the exotoxin part, which is later on mixed with your pertussis and tetanus. So this becomes your DPT, or just with your tetanus toxoid, that will be your TB vaccine. So since this is a toxoid, this usually is given every 10 years. Or you can, in the early part of the disease, you can give antitoxin. Okay, so that is your passive immunization. And how do we treat? We treat it by giving your penicillin and your macrolide erythromycin. So these antibiotics are given to your patients, to your carriers, and even those who have close contact to eliminate bacteria. Now, another killer in our time is your Streptococcus pneumoniae. Your Streptococcus pneumoniae gives an incomplete or alpha hemolysis in your blood agar. Your Streptococcus pneumoniae has a capsule, and another property of it is catalase negative. So these are, how do they look like? These are gram positive, so they are blue, spherical or football shaped cocci, diplococci. So it has some problem with their appearance. Can they be cocci, or they can be diplococci? And since it contains a capsule, it will have capsular swelling in the presence of specific anticapsular antibody called your positive Kellan reaction or your Neufeld reaction. So how do we have problems with your Streptococcus pneumoniae? The main pathology is aspiration of your nasopharyngeal secretion in the lower airways. When you aspirate your nasopharyngeal secretions, your lower airways will lead to rapid growth of your pneumococci in the alveolar spaces. So what are the risk factors? One is you can have a reduced clearance of your ciliated epithelium in the upper airway, secondary to a preceding viral infection. So usually a Streptococcus pneumoniae infection precedes a viral infection, or right away if you are a smoker, because these two conditions, this infection and this reaction, will reduce the clearance of the airway to the disruption of your ciliated epithelium. The presence of the capsule, which has an antiphagocytic property, is required for virulence, and your Streptococcus pneumoniae has pneumolysine, which is similar to your streptolysine O, which can lyse cells. And it also has your pneumococcal immunoglobulin A protease. So this is an enzyme that will cleave your secretory IgA, thus increasing the adherence So stickability now to the mucosal cells. And also your strep pneumonia contains your neuraminidase, which is used to spread. So they will promote bacterial spread in your alveolus, in your tissue. So what are pneumococcal diseases? These are your typically community acquired pneumonias. And how do they will present to you in the ER, in your clinic? Your neighbor may come to you with cough and high-grade fever at 102 to 105 degrees centigrade, and they have rigor. So what is rigor? Rigor is just chills. They have chills and they have a productive cough. They produce pain, and whenever they cough, they complain of chest pain. It's your pleuritic pain. Do you know what pleuritic pain? Even if you inhale deeply and then you cough, it is so painful. It's due to the inflammation of the pleura from either your bronchopneumonia, which is will usually look like patchy pneumonia, or your lobar pneumonia, which involves one or more lobes are seen in your radiographs. Unfortunately, if your Streptococcus pneumoniae can be so deadly that it causes the spread in your blood, your bacteremia. This is found in 25 to 30% of patients and will lead to pneumococcal meningitis. Remember, your strep pneumonia is the leading cause of bacterial meningitis in people older than 18 years. So remember, strep pneumonia is the leading cause of bacterial meningitis in people older than 18 years of age. And for children, it is the most common cause of otitis media and sinusitis. And again, unfortunately in children, this is the most common cause of sepsis in children with sickle cell disease, especially those who are suffering from sickle cell disease and dysfunctional spleen. Why? Because a functioning spleen is required for the normal elimination of your bloodborne, your bacteremia, which is secondary to your strep pneumonia. If there is no functional spleen to eliminate your strep pneumonia, then it can lead now to sepsis. And again, a note, if ever you have a nephrotic syndrome that suddenly develops peritonitis, remember always your Streptococcus pneumonia is the most common cause of peritonitis in children with nephrotic syndrome. So there are many most common in here, okay? Most common cause of otitis media and sinusitis, most common cause of sepsis in children with sickle cell disease and dysfunctional spleen, and the most common cause of spontaneous peritonitis in children suffering from nephrotic syndrome in a. So remember the most common, it usually will come out in exams. Okay, now we talk about the epidemiology of your pneumococcal infection. The transmission of your pneumococcal cocci usually occurs via aerosols, so it's from sneeze, cough, and when you are talking to an infected person, followed by later on it will infect your nasopharyngeal area. Then you aspirate now your nasopharyngeal area. So in those who have 4 seasons, in the temperate areas of the world, infection is most common in winter and spring. So who are the at-risk groups? At-risk groups are your very young children, the elderly people, those who have donor spleen for whatever reason, and those who are immunocompromised individuals, those who are on steroids, those who have cancers, those who have HIV. So all of those children and people are at risk. Prevention and treatment of your Streptococcus pneumoniae. Fortunately, again, just like your Corynebacterium diphtheria, there are many brilliant scientists and doctors who have gone ahead of us who have to face so many deaths in their practices or in their community and push them to develop vaccines so that they can control the cause of this death due to Streptococcus pneumoniae. So they develop capsular vaccines. Okay? capsular vaccine, polysaccharide capsular vaccines with or without conjugated protein for those at risk populations in children. But there are now the problem of the misuse of penicillin now has led to the increasing resistance of your pneumococcal streptococcal pneumoniae to penicillin, and they are isolated from those children attending from daycare centers. So how do we treat this bug? We can treat it with the drug of choice would always be penicillin, but there are other alternatives to it, your macrolides, your erythromycins, your clarithromycins, your azithromycins, your cephalosporins, first and second gen and third gen, and your fluoroquinolones are all effective alternatives in treating streptococcal pneumonia that causes your otitis media, sinusitis, and your pneumonia. And for those suffering from the dreaded meningitis secondary to your Streptococcus pneumoniae, you can give your cefotaxime and your ceftriaxone. Okay, so these are nuggets of truth that you have to remember. There are two organisms that are the most common cause of your acute otitis media and your sinusitis. These are your Strep pneumoniae and your Haemophilus influenzae. And there are four organisms that has capsules and will cause meningitis. Three are bacteria and one is yeast or fungi. Your three bacteria are your Strep pneumoniae, your H. influenzae, and your Neisseria meningitis. And your yeast is your Streptococcus neoformans. This one is they are acquired through bird droppings, the poops of the birds and the fowls. So that's it. Now we have tackled the start of your pathogenic bacteria. We tackled and learned about your Corynebacterium and your Streptococcus pneumoniae. So it's goodbye for now. Maraming salamat po. See you on your next session. Study very well.